Deputy Vice Chancellor, Research, Innovation and Strategic Partnerships, the Registrar, University Librarian, Provost of the College of Medicine, Provost of the Postgraduate College, the Dean, Faculty of Clinical Sciences, Deans of other faculties and of students, Directors of institutes and centers, Heads of department, distinguished guests, ladies and gentlemen. The 544th University of Ibadan inaugural lecture will be delivered this evening by Professor Adebola Orimadegun of the Institute of Child Health on behalf of the Faculty of Clinical Sciences. Professor Adebola Orimadegun was born on July 7, 1970 in Ijebu-Igbo, Ogun State, to late Samuel Ademilopo and late Juliana Omowejowo Orimadegun of the Abereowo family, Sajuku compound of Onaido, Ayetoro Ekiti in Ekiti State. He received his early primary school education at All Saints Primary School, Atikori, Ijebu-Igbo, from 1976 to 1980, and then transferred to the Seventh-day Adventist Primary School, Ayetoro Ekiti, Ekiti State, from 1980 to 1981, because his parents believed that the quality of education in Ekiti State was superior at that time. He later attended Ayetoro Iloro High School in Ayetoro Ekiti, Ekiti State, from 1982 to 1987. He studied at the Institute of Basic and Advanced Science of the Kwara State Polytechnic Ilorin for the Higher School Certificate, HSC, from 1988 to 1990, earning distinctions in all the three subjects at the advanced level. This earned him admission to study medicine and surgery at the University of Ibadan in 1990. He was awarded MBBS degree in 1997 and served as a house officer at the University College Hospital Ibadan from 1997 to 1998. From 1998 to 1999, he had his mandatory National Youth Service Program at the General Hospital, Ikara, Kaduna State. Professor Orimadegun had his residency training in the Department of Paediatrics at the College of Medicine, Ibadan, from the year 2000 to 2006. He was awarded the Fellowship of the West African College of Physicians in April 2006. During his residency training, he also completed a master's degree in epidemiology in 2005. He worked as a hospital consultant at the University College Hospital Ibadan through the Department of Paediatrics for 14 months between 2007 and 2008, before joining the services of the University of Ibadan as Research Fellow 1 on March 13, 2008. He obtained a Master's of Science degree in clinical trials from the London School of Hygiene and Tropical Medicine, University of London, with distinction in 2013. He later obtained a PhD in epidemiology from the University of Ibadan in 2017. Professor Orimadegun rose through the ranks, becoming a senior research fellow in 2011, reader in 2014, and full professor in 2017. Professor Orimadegun has served the University of Ibadan as a member of the Development Committee, the College of Medicine Curriculum Committee, and the University College Hospital Research Committee as chairman. He also served as an elected member of the University of Ibadan Health Sciences. He has been a member of Senate since 2017. Professor Orimadegun has received various research funding, notably from the Tertiary Education Trust Fund, TED Fund, through the University of Ibadan Malaria Consortium, Williams and Flora Harewood Foundation, World Health Organization, WHO, Management Sciences for Health, United States Agency for International Development, USAID, the Institute of Education in the United States, African Population and Health Research Center, and the Bill and Melinda Gates Foundation. Professor Orimadegun has also garnered international recognition with TRIP funds from major organizations such as the World Health Organization, African Population and Health Research Center, Keystone Symposia, and the Institute of Education in the United States. His expertise is in high demand worldwide, and he has acted as an external examiner for several universities, both in Nigeria and abroad, including the University of Cape Town in South Africa and Wageningen University and Research in the Netherlands. Professor Orimadegun has received numerous awards and accolades from his outstanding work, including the prestigious Best Nigerian Pediatrician Researcher of the Year 2022 award from the Paediatric Association of Nigeria for outstanding contribution to maternal and child health in the sub-region. His dedication to medical teaching and research is unwavering, as evidenced by his positions on many boards of organizations, university, and hospital committees, as well as the international organizations such as the World Health Organization and Friesland Capina Institute. He has supervised so far 15 resident doctors who have earned the professional fellowship from either the West African College of Physicians or the National Postgraduate Medical College in Paediatrics, as well as 30 master's degree candidates, 2 MPhil candidates, and a PhD candidate. Some of Professor Orimadegun's articles have helped to shape global policies on malaria treatment and neonatal care. He is a resource person for the West African College of Physicians. He teaches and examines for the primary Part 1 and Part 2 fellowship examinations. Professor Orimadegun is a member of many learned societies, including the Paediatric Association of Nigeria and the Nigerian Medical Association, NMA. Since 2019, he has served on the board of Ekiti State University Teaching Hospital. His work with the Institute of Child Health, as well as his leadership role in child health research and education, demonstrate his enthusiasm for teaching and mentoring. Professor Orimadegun has over 100 peer-reviewed journal publications and book chapters, as well as large citation profile. As at January 30th, 2024, his Google Scholar Citation Index was 2,225 with an H index of 28 and an I-10 index of 57. Professor Orimadegun is happily married to Dr. Bose Etanieme Orimadegun of the Department I have to be careful so that I will not massacre that name. Etanieme Orimadegun of the Department of Chemical Pathology in our College of Medicine. And the marriage is blessed with children who are making important contributions in their respective field. I now invite Professor Orimadegun to present his lecture titled Child Health Dynamics, Chances, Choices, and Consequences. Professor Orimadegun.
the Vice Chancellor, Deputy Vice Chancellor Administration, Deputy Vice Chancellor Academic, Deputy Vice Chancellor Research, Innovation and Strategic Partnerships, the Registrar, University Librarian, Provost of the College of Medicine, Provost of Postgraduate College, Dean of Faculty of Clinical Sciences, Deans of other faculties, Dean of Students, Director of Institutes and Centers, Heads of Department, gentlemen and women of the press, distinguished ladies and gentlemen, I extend to you all very warm welcome this evening. I would like to express my gratitude and praise to Almighty God, who has enabled me to deliver this inaugural lecture. I also want to thank the Vice Chancellor, Professor Kayode Adebola FES MNI, for giving me this opportunity to present the 544th inaugural lecture, which is the first from the Institute of Child Health. This lecture is built upon the hard work of dedications of the founding fathers and researchers who have come before us, which we continue to build upon today. What is child health? Child health encompasses the overall well-being of children from age 0 to 18 years, addressing their physical, mental, and social health. Professionals in this field include pediatricians, nurses, and public health practitioners who work to promote the optimal child development. They address preventive care, diagnosis, treatment, nutrition, mental health, and injury prevention. The Institute of Child Health, University of Ibadan, Nigeria, was established in the late 1950s to address the significant inequalities in child health. With a grant provided by United African Company, the University of Ibadan was able to fully establish the ICH in 1960. The main objective of the institute were to conduct research on health issues affecting Nigerian children and provide educational programs in the field of child health. Dr. William Collis secured the funding from Rockefeller Foundation, which enabled the institute to conduct research and teach in rural pediatric medicine and nutrition. Dr. Collis' dedication and effort led to the establishment of the ICH, not only in Ibadan, but also in Zaria and Lagos. Professor Ralph Edrickson significantly advanced the understanding and treatment of children in Nigeria. His insight into malnutrition, impact on brain development, and the importance of traditional practices like breastfeeding left lasting impact on child health policy and practices. The Rockefeller Foundation and the UAC worked with the ICH on the goal and objective of WHO and UNICEF. This partnership focused on promoting growth and cultivating healthy children for national development. Mr. Vice Chancellor, sir, permit me to acknowledge three influential and early figures who have made noteworthy contribution to our institute. They are Professor Adewale Laditon, late Professor Folashade Akikugbe, and Professor Olayemi Omatade, who is seated right in the audience. Their hard work and achievement, as well as those of their predecessors, form the foundation for the successes we celebrate today, as well as the advancement we strive for in the future. Child health dynamics. Child health dynamics refers to the intricate dance of growth and development that children go through from birth to adulthood. This dance starts from the first breath and is influenced by various factors, both visible and invisible. It starts with interaction with the genes and environment, which shape their health and growth trajectory. Choices and action also play a role in this dance, with parents, society, and policymakers initially making decisions for children. But as they grow older, children attain the ability to make choices regarding their diet, habits, education, and health seeking. However, this lovely start is only the beginning of a delicate dance of growth and development, a trip heavily influenced by child health dynamics. Understanding and navigating these dynamics, therefore, are vital to supporting children's health and well-being throughout their journey from birth to adulthood. Dance and the dance stage. In the child health dynamics dance, each child creates their own dance to symbolize their growth and health changes from pregnancy to adulthood. Factors such as a supportive family and hereditary pattern shape the dance. The stage of life in where the dance begins, influenced by chances and genetic inheritance from parents. Additionally, a child's environment, including nutrition, air quality, and family finance, also play a pivotal role. Different individuals may experience this stage differently, with some finding it relaxing and comforting, while others struggle with it. Regardless, the dance of life commences and continues at this point. A show of choices, actions, and reactions. Children often have limited control over important aspects of their lives, such as diet, vaccination, habits, and schooling. Initially, these choices are often made by parents, society, and similar to choreography in a dance. However, as children grow older, they gain more autonomy to make these decisions themselves. These choices have consequences, much like every move in a dance. Eating a nutritious meal, for instance, provides immediate satisfaction, while receiving a quality education yields long-term benefits. Implementing healthy practices and policies supports growth and development, creating an harmonious sequence in the dance. On the other hand, poor health decisions and child health policies can lead to disease and disability. The audience, including us seated here, plays a crucial role in this performance. Our support, criticism, or lack of engagement of influences public health practices and policy and resources for child health. Choreographers such as lawmakers, healthcare professionals, educators, and scholars, they work to create the best sequence, remedies for disruption. It is the responsibility of all to ensure that the music encompassing public health, medical treatment, and education empowers children of all ages to perform well in all life stages. Critique, dance, and evaluation. Scholars research in child health dynamics, and this can be likened to a dance performance evaluation, focusing on analyzing the technique of child health and assessing intervention. Scholars observed, they analyze, and criticize. My studies at the University of Ibadan and the University College Hospital have examined this dance technique in detail for many years. My studies examine events that influence chances, choices, and consequences, and how interventions like policy programs, drugs, and immunization protect the dancers, that is the children. Every study I have conducted in collaboration with others increase the dance, the rhythm, improve the children's immediate and long-term outcome. Interplay of chances, choices, and consequences. Chances and consequences play a vital role in children's health. Factors such as birth, race, socioeconomic status, and genetics can affect child health. Parental choices like prenatal care and healthy lifestyle also impact children's well-being. Socioeconomic status play a role, with wealthier family having more resources for healthcare and education. Public policies, quality medical treatment, dietary initiative, and education intervention also affect children's health. My journey and future path. I'm a scholar and an advocate for children, for child health to be specific. I'm committed to improving child health through research, practice, and education. My belief is that every child deserves a healthy life, which fueled my passion for research. I have studied how birth circumstances, family decisions, and policy choices shape children's health outcome. In this lecture, I will present evidence based on my experience and contributions to knowledge and practices. Together with my colleagues, we have explored child health data and experiential insight. I will present the outcome of our work, highlighting some of the benefits it has brought to the Nigerian children we serve, both nationally and internationally. I have focused on malaria and its impact on children, neonatal health, and child nutrition. Now, early malaria treatment outcomes. In a study, we examined the impacts of early home treatment for fever and the use of anti-malaria drug on severe malaria in children. Our study showed that relative risk of death associated with chloroquine was 4.25 more, which indicates that patients treated with chloroquine had over 4 times the risk of death compared to those who did not receive chloroquine. We concluded that early home treatment with inadequate anti-malaria did not only fail to prevent severe malaria, but also increased the risk of death. The study emphasized the importance of using effective anti-malaria and quick diagnostic techniques in home setting and provided insight into the importance of making informed choices for children's health. Malaria and hypoxaemia, which means low oxygen level in the blood. My team and I conducted another study that focused on relationship between hypoxaemia, low level of oxygen in the blood, and severe falciparum malaria in children. The study found that hypoxaemia predicts death from severe malaria in this population, highlighting the need for routine oxygen saturation testing in severe malaria cases. The overall mortality rate was, among the patients we investigated, was 8.1%, and with hypoxemia, pneumonia, metabolic acidosis, and hypoglycemia identified as predictors of death. The study recommended the introduction of pulse oximetry as part of the case management of severe malaria, and also emphasized the importance of prompt recognition and treatment of hypoxemia to improve patient survival. Performance of malaria rapid diagnostic tests. In another study, we compared 3 malaria rapid diagnostic tests with microscopy and polymerase chain reaction to determine which one is the most effective diagnostic tool. The MRDT evaluated were SD-Bioline, CareStat, and Paracheck. The accuracy of the 3 MRDT was 79.5%, 80.5%, and 81.1% respectively, compared with microscopy, which was 86.8%. Although MRDT offer a quicker and more accessible method of diagnosis, of microscopy provides higher specificity and accuracy and shows substantial agreement with PCR. However, the MRDT showed consistent performance, indicating that any of the 3 brands could be used for malaria diagnosis in Nigeria. Persistence of positive MRDT after treatment. To understand the dynamics of the persistence of HRP2 antigen in children's blood after successful treatment of malaria treatment, we carried out a study that followed up children and tested them with MRDT for 28 days. Our results show that RDT positivity lasted an average of 23 days after treatment, longer than microscopy, result indicating a limitation of RDT in post-treatment scenario. The figure display showed that microscopy positive cases decreased rapidly after malaria treatment, while RDT positive cases decreased slowly. MRDT can produce false positive results, causing confusion for healthcare provider in interpreting active infection. Consequences of restricting malaria treatment to RDT positive tests. In another study, we examined the consequences of restricting anti-malaria treatment to children who tested positive for malaria through rapid diagnostic tests. The research focused on whether this restriction would lead to adverse events within 28 days after treatment. Febrile children were screened. MRD positive children received malaria treatment, while MRD negative were treated for any other diagnosis. We found that the likelihood of acquiring malaria within 28 days after treatment was higher in the MRD positive group. MRD positive group also had a higher percentage of anemia on day 28 and fewer unscheduled visits for febrile illness. The study also showed that children who initially tested positive to malaria had a greater chance of reinfection. Nonetheless, limiting treatment to only MRD positive children did not result in any negative health consequences. Our study highlights the importance of making informed choices in child health by limiting anti-malaria therapy to RDT positive children in order to optimize resource allocation. This approach can help decrease the improper use of anti-malaria medication and manage reinfection and prevention adequately. Efficacy of pyrrolizine, artesunate versus artemether-lumefantrine study. We compared the efficacy and safety of pyrrolizine, artesunate, and artemether-lumefantrine in treating acute uncomplicated malaria in children in Nigeria. Our study found that PA was more efficacious than AL with a higher satisfactory clinical and parasitological response rate on day 28 in the PA group. Treatment failure was more likely in the AL group, especially before day 21. Adverse effects in both groups were minor and similar to mere malaria symptoms. This research suggests that PA could be a viable alternative to AL in places where AL efficacy has declined. The study recommends including APA in Nigeria's National Malaria Treatment Guideline for children with uncomplicated malaria. The study also emphasizes the importance of monitoring and evaluation anti-malaria treatment in malaria endemic countries to ensure the use of effective medication. I also worked in the area of malaria prevention, so malaria prevention practices. We conducted a study on malaria prevention practices during pregnancy and its impact on birth outcome. We found that 95.6% of 800 pregnant women enrolled in this study used a form of malaria control method, with window nets and insecticide spray being the most common. The use of sulfadoxine pyrimethamine was associated with higher birth weight and gestational ages, while herbal remedy were linked with lower birth weight and gestational ages. This study emphasizes the importance of effective prevention technique and access to sulfadoxine pyrimethamine for improving birth outcome in malaria endemic area. G6PD deficiency and malaria. G6PD simply means glucose 6-phosphate dehydrogenase deficiency. It's an enzyme that is used necessary in maintaining the integrity of red cells. Two of our studies examined G6PD deficiency and malaria. The first study found that G6PD deficiency was more common in severe malaria cases, and G6PD deficient male had a lower risk of impaired consciousness and severe malaria anemia, and no death occurred among the deficient patients. Significantly lower chance of developing severe malaria at PCV less or equal 10% and PCV less or equal 15%, but no association between G6PD status and the various degrees of anemia in the female counterpart. Personalized medicine, therefore, was suggested as strategy to be considered when dealing with G6PD status in patients with malaria, and when prescribing anti-malaria medication like primaquine that can cause severe hemolysis. G6PD deficient individual, this needs to be considered. Screening for G6PD deficiency in malaria endemic region is therefore essential to guide treatment decision. Plasma protein as biomarker of severe malaria. In another study, we utilized a high-throughput proteomic profiling on plasma sample to identify disease groups such as cerebral malaria, severe malaria anemia, and uncomplicated malaria. The results show that the plasma proteome pattern accurately defined the different types of malaria syndrome, with accuracy of over 70% in discriminating between cerebral malaria and severe malaria anemia. These findings suggest that protein profiling could be a powerful tool for malaria diagnosis and early detection. Our study results offer clinical and public health benefits by improving treatment for severe malaria. It introduces new diagnostic tools for timely treatment decision and provides insight for developing prevention and control strategies. The role of epsidin in malaria. In a study with biomarker in malaria, we investigated epsidin level in different forms of malaria, such as cerebral malaria and severe malaria anemia, and its connection to inflammation and iron status. The goal was to improve malaria diagnosis and treatment in children. Epsidin level were found to be higher in severe malaria anemia, suggesting a response to inflammation or iron dysregulation. Interleukin-6 levels were significantly higher in cerebral malaria, indicating strong inflammation, and serum transferrin level and erythropoiesis remain stable. But ferritin level was elevated in cerebral malaria and severe malaria anemia, reflecting mobilization of iron store in response to infection and inflammation. These findings have implications for managing severe malaria anemia and cerebral malaria, as well as developing diagnostics too. Epsidin has the potential to serve as a biomarker for severe malaria, guiding treatment strategies. I also did some work on neonatal health, so I will present my contributions to neonatal health. Maternal and neonatal immunity first. We conducted a study to assess tetanus immunity level in first-time mothers and their newborn. The objective was to examine the factors influencing immunity against tetanus in both groups. Participants were selected from healthcare facilities in Ibadan, including urban and rural communities. Results revealed that 28.7% of our mothers and 36.5% of their newborns had non-protective tetanus immunity. Protective immunity was more common in urban areas compared with rural area. Factors like residing in rural area and receiving less than 2 doses of tetanus toxoid immunization during pregnancy were associated with non-protection in the newborn. Our findings imply that despite the effective vaccine being available, neonatal tetanus remains a challenge in Nigeria. This called for more research and intervention and focus on maternal immunization and tetanus prevention, particularly in rural areas, to safeguard our newborn health. These findings have crucial implications for public health planning and efforts to eliminate neonatal tetanus and enhance child health in Nigeria. As a follow-up to that research, in a longitudinal study, we conducted and we examined the persistence of tetanus immunity in the newborn. The study included 244 primiparous mothers and their newborn in Ibadan, Nigeria. Protective immunity was measured using tetanus quick stick on days 1, 7, and 14 post-birth. Results show that 63.5% of newborn had immunity on day 1, increasing by 77.78% by day 14. Factors like urban residence, maternal age, and gestational age influenced persistence of immunity. It was recommended that neonates should receive 8 years injection for protection if their mother hadn't received enough tetanus toxoid injection during pregnancy. Predictive factors for immunity persistence were also identified, and these findings highlighted the importance of tailored maternal vaccination program and informed strategies in maternal and newborn care, especially focusing on our rural communities. My contributions to child nutrition. In 2010, a study was done in Nigeria to examine the body mass composition of children under 5. Our goal was to find a predictor for hospital admission outcome, allowing for early intervention and management strategies to reduce child mortality related to undernutrition. Our study found a strong link between body mass composition and admission outcome, highlighting certain compositions that increase the risk of adverse outcome. The mid-upper arm circumference emerges as the only independent predictor of mortality. This provides healthcare providers with a new method to assess and foresee risk in this age group. Body mass composition can predict child health outcome and guide treatment to optimally educate public health program and policy decision making in child nutrition. In another landmark study, which we conducted in 2016, we investigated the metabolic changes in Nigerian children with severe acute malnutrition using liquid chromatography mass spectrometry and gene sequencing. The study found that the plasma metabolome of malnourished children had significant alteration compared to healthy control, with depleted amino acid, scarce phospholipid, and decreased oxylipid level. However, the stool metabolome and microbiota did not show significant differences. The study highlighted the importance of comprehensive metabolomic profiling in understanding malnutrition and informing clinical management and public health strategies. This study underscored the complex connection between dietary deficiencies and metabolic imbalances in child health, emphasizing the need for early diagnosis and precise dietary therapy. In a follow-up study to that, we investigated aflatoxin exposure and childhood development impairment in Nigerian children with severe acute malnutrition. Our investigation indicated that severe acute malnutrition children had greater amount of aflatoxin B1 lysine adults than control. Aflatoxin were also considerably greater in stunted children. Kwashiorkor children had greater aflatoxin level than marasmic children. This was the first human aflatoxin quantification study using high-resolution mass spectrometry in Nigeria and West Africa sub-region. The study shows that aflatoxin exposure negatively impacted malnourished children's nutritional results and we emphasize the need for food safety in nutrition program to support child growth and development. Concluding remarks. Mr. Vice Chancellor, sir, I have, in the last few minutes, discussed the concept of chances, choices, and consequences in child health dynamics. I have explained that there are factors beyond a child's control that influence their health. Choices made by parents, guardian, and society can either benefit or harm a child's health, leading to various outcomes. I have emphasized the necessity of a comprehensive approach to child health, considering biological, environmental, and social determinants of health. My research and advocacy efforts, notably in malariology, newborn health, and child nutrition, were highlighted. They stressed the importance of utilizing medical science, public health policy, and community engagement in tackling evolving challenges in child health. The interconnectedness of choices, chances, and consequences in child health was buttressed with my findings from my research, with a focus on empowering individuals, families, and communities to make informed choices for better child health outcomes. Recommendations. I believe the following recommendations will improve the chances of child survival and choices that enhance child health outcome in Nigeria. For parents, our parents must begin to seek to know and understand the significance according to the National Schedule on Immunization Program. Our parents should educate children about appropriate hygiene habits, including hand washing, to minimize infectious disease spread. For policymakers and others in government, it is important to look at how we can strengthen our healthcare delivery to take care of children more than we are currently doing. We need to improve nutrition and food security. We need to strengthen water, sanitation, and hygiene. Existing programs are there, but we need to upscale them and make them to reach hard-to-reach communities. We need to invest in education more. We also need to address social factors like poverty, eradication, and be sincere about it for the sake of our children. We need to promote research and innovation. Government needs to provide more funding to support local research so that we can solve our local problems. We need to enhance governance and policy that are targeted and directed at addressing children's health. For our university, sir, Mr. Vice Chancellor, sir, we need to foster multidisciplinary research among different groups within this university. Enhance community outreach programs that brings academics close to their local communities. We need to enhance child health curriculum in relevant departments, not only in the Department of Paediatrics and Institute of Child Health, but wherever child health is being touched. We need to collaborate with local and international health agencies. Particularly, we need to work more with primary health care development agencies. Acknowledgement. I would like to begin by expressing my sincere gratitude to the Almighty God, who has perfectly planned my life to ensure that I have access to everything I ever needed. He has protected me from everything that could potentially overwhelm me. He has been the glory and lifter of my head. I give glory and adoration and honor to him for his grace, mercy, and enablement. Mr. Vice Chancellor, sir, it is with joyful heart that I thank my beloved late parents, Mr. Samuel Adebola and Mrs. Omowejuwo Adebola Orimadegun. Both, I believe, will have loved to be here today. I'm particularly grateful to my mother, who made enormous sacrifices to see that I got the quality of education she never had. I'm immensely indebted to my late uncle, most senior Apostle David Afolabi Olaiya, who practically offered me a scholarship and supported my dream of becoming a doctor from secondary school through advanced level to the end of my university education. How joyous will it have been for him to witness my inaugural lecture today. I also acknowledge the motherly care of my heart, the late Mrs. Ebun Victoria Olasomi, who took care of me while I was in school at Ayetoro Ekiti. Next, I extend my gratitude to my siblings, Mrs. Bukola Olatunji, Mrs. Adedolapo Adegboye, and others. My special thanks also goes to Madam Mary Olaiya and Madam Felicia Olaiya for their love and care. I thank my cousins, especially Mr. Adebola Olaiya, Dr. Olaniyi Olaiya, my closest companion in the Olaiya family, and others that are listed on the slide being projected. I also thank other members of my family, the Orimadeguns, the Aberowos, the Olasusis, and the entire Sajuku clan. Thank you all. I wish to express my deepest appreciation to the entire members of my wife's family, the Yakubus and in-laws, including Professor Mijinyawa and his family. They have become my own through the bond of marriage and shared experiences. To my late father-in-law, Mr. Ogil Yakubu, whose memory I cherish with profound respect and affection, I say thank you. To my beloved mother-in-law, Mrs. Abibat Yakubu, Mama Imegba, whose warm strength and unwavering support has been a source of comfort and encouragement for us at home. To my wife's siblings, many of who are too many for me to mention, I thank you all. I am extremely appreciative of my teachers from primary school to date, the names and location of many of whom I cannot even recall now. I thank Dr. P.E. Olumisi, Dr. R.A. Badigeshin, and Dr. Molola Ayola for introducing me to research very early in 2001. I am grateful to Professor O. Oshurende for giving me the best supervision and showing me the value of laboratory hands-on experience by insisting on my total participation in malaria microscopy and culture and GCPD screening experiment as I pursue my research towards the fellowship dissertation. Professor Olusegun O. Akiyenka and Professor Felix Akibami are not just my academic fathers. Our relationship has gone beyond the sphere of our profession. These duos have practically touched every aspect of my life, including family, The depth of their commitment to my well-being and success is a testament to their exceptional character and dedication to nurturing young scholars. Professor Kinyeka read and advised on the content of this manuscript of this lecture. It is rare to find mentors who invest themselves so thoroughly in the growth of their mentees, and I consider myself extraordinarily fortunate to have been under their tutelage, so I cannot thank them enough. I am deeply grateful to Professor Olajemi O. Omotade for allowing me to be employed at the Institute of Child Health and for guiding me during my career journey. I'm also indebted to other esteemed pediatricians and teachers who significantly contributed to my training, namely Professor Kike Lomo Oshunusi, Professor A.G. Falade, Professor Oluwatoyin Ogunkule, Professor S.I. Omokodion, and Dr. Adanze Asinobi, who is the current head of department of pediatrics. She is a mother in need and in deed. To you all, I say your tutelage and other support during and after my residency training have been part of the reason for my pride today. My appreciation goes to members of staff of the Institute of Child Health for their hard work and cooperation, which are uplifting the image of our dear institute. Professor Olukemi Amodu, Professor Adeshola Olumide, and my other colleagues and co-workers, both teachings and non-teaching. You have all made me proud. Thank you. I am grateful to Professor Ikolu Alagoju for playing the role of big sister in my family and me since my days of internship. I thank Professor Brown, Professor Oladokun, Dr. Tongo, and my other colleagues in the Department of Paediatrics. I am deeply grateful to Professor Catherine Falade and Professor Ayodele Jegede for their invaluable mentorship and support in both my academics and personal journey. Their impact extends beyond the wall of the university. They taught me the significance of perseverance, ethical conduct, and compassion. Their unwavering support, valuable advice, and endless kindness have left an indelible mark on my life and family. I am grateful to Professor E. Ebangboye, who encouraged me to enroll for PhD in epidemiology, and he offered to supervise me. Thank you, sir. I am delighted to extend my profound appreciation to the esteemed governor of Ekiti State, His Excellency, Mr. Abiodun Abayomi Oyebanji, and his gracious wife, Her Excellency, Dr. Olayemi Oyebanji, for allowing me to extend my community service by serving as a member of the board of Ekiti State University Teaching Hospital from 2019 to date. I'm also grateful to the chairman of the board, Dr. Adebola Orimadegun, members of the board, and the chief medical director and director of admin of that teaching hospital. Thank you for your support. I'm grateful to Dr. Akin Fajola and all members of staff of Community Health Department of SPDC, Port Harcourt, for allowing me and giving me the chance to spend my sabbatical leave in their facilities. Thank you very much. I thank all those who have collaborated and ever worked with you over the years, locally and internationally. The list I cannot just continue to mention. Please also allow me to extend my appreciation to the following: members of the AIHS graduating class of 1987, that is Ayetoro Iloro High School graduating set of 1987, members of graduating MBBS class of 1997, and to our numerous special family friends. I would like to specially mention Mrs. Olajumoke Abokulu, Dr. and Mrs. Agbaje, Dr. Bolajoko, Dr. Mrs. Salami, Dr. and Mrs. Salami, Professor and Professor Mrs. Bolagade Adeshiji, Dr. and Mrs. Shoritire, Dr. and Mrs. Asekume, Dr. and Mrs. Oshofora, and Dr. and Mrs. Fadirera Babalola. To my contemporaries during residency, Bayo, Ese, and Wasiu, I am grateful to you all. To many doctors I have ever supervised or mentored, who are my supporters and advisors to date, please permit me to mention Doctors Adepoju, Abdurrahim, Folusho Balogun, Fagbohun, Adigun, Omisanjo Busayo Babatunde, Akinyoye, and Oladeyin. I thank you all. All the postgraduate students of the Institute of Child Health and other departments that have gone through me, you have all contributed to my success today. Thank you. Professor Ademowo, Professor Iwalewa, Professor Talabi, Professor Fasula, Professor G.R.E. Anna, and the late Professor T.K. Amzat and his wife, Dr. Adepoju, Dr. Abdumalik, Dr. Gumboshi, Dr. Bukola Bobola, Dr. Nyade, Akikumi, and Akim Yusuf. I hold all of you a special place in my heart. Thank you for your kindness. Current resident of the Department of Paediatrics, 2 minerals for me to mention. Thank you for your always supporting me. I am grateful to Pastor Mrs. Valentina Akinika for her motherly role and spiritual support. To my office and research staff who have worked tirelessly in the trench, especially assistants who work with me on projects like SUMMUP, TED Fund, Countdown to 2030, TESS, and Aladdin, ongoing Aladdin project. I appreciate and love you all. I am indebted to all my spiritual family members of the Living Faith Church, Winners Chapel, Akobo Ojuni, for their prayers and support in various times. I want to especially acknowledge my father and my mother in the Lord, Bishop Thomas Aremu, and Pastor Dr. Mrs. Elizabeth Ateremu, who is seated here. The resident pastor of Akobo Ojuni, the associate pastor, and all other pastors. I thank you all. I'm grateful to Elder and Elder Mrs. Oyeniyi. Your many years of counsel and prayers are well appreciated. I also thank the family of Oluwasakin, Odederi, Olan, and Olan Lokun for their support. I thank all the organizations, local and international, that have supported my research. I thank the University of Ibadan, past and present administration, for providing me with a job that allowed me to do the work I described earlier. My special thanks to the Provost of the College of Medicine, Professor Olayinka Omigbodun, FAS, and the Dean of Faculty of Clinical Sciences, Professor Ogundiran, for their love and support over the years. I also thank the University College Hospital, previous and current administration, for the honorary consultant position and limitless access to patients for me to do my research. I would also like to thank all our research communities and volunteers. Thank you very much. I want to express my sincere gratitude to our amazing children, Isaac and Israel. You have made a journey, made a major source of joy to Bose and me. As you both had lead admirable life and success in your chosen career. Thank you. My adopted children, Abiola, Blessing, Oluwaseun, Ope, and Emole. Thank you for being there. At this point, Mr. Vice Chancellor, sir, I would like to express my heartfelt gratitude to my dear wife, Dr. Bose Etaname Orimadegun, who has been a shining star in my life. Our unwavering support, profound insight, and endless patience have not only built strong foundation for our home, but have also played a significant role in my academic success. Your sacrifices and unwavering faith in my work have constantly motivated and encouraged me. Bosse, I'm truly grateful for your love and care as you have selflessly balanced your own responsibility while enriching our family lives. Bosse, I will forever be grateful for your love and unwavering presence. I love you. Mr. Vice Chancellor, sir, distinguished ladies and gentlemen, it is a convenient point for me to say I thank you all for your attention.